This podcast is not CME eligible. If people do want to learn more about CME eligible podcasts, Alex, what do they do?
They can go to geripal.org/CME.
And on to the show. Welcome to the Jerry Pal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who do we have with us today?
We have an honored list of guests today. I'm going to start with Bill Applegate, who's a geriatrician and a palliative care doctor, former editor-in-chief of the Journal of the American Geriatric Society, or JAGS, and in that capacity recruited both Eric and me to the journal, and is a retired faculty at Wake Forest. Bill, welcome to the Jerry Pal podcast.
Thank you.
We're also delighted to welcome John Burton, who's a geriatrician and formerly director of the Division of Geriatric Medicine at Johns Hopkins for 35 years. John, welcome to Jerry Pal.
Thank you. It's an honor.
And we're delighted to welcome back Melissa Aldridge, who is a former banker turned health services researcher and is vice chair of research at Mount Sinai School of Medicine in the Department of Geriatrics and Palliative Medicine, and is also one of the Ascent, which is this national research network, multiple principal investigators. So, Melissa, welcome back to Jerry Pal.
Thanks for having me.
So we have an exciting podcast. This is a little bit different. We're going to be talking about transitions. You know, a lot in geriatrics and palliative care, we think about like transitions from home to different living environments. We're going to be talking about that today in this podcast to CCRCs, or continuing care retirement communities, assisted living facilities, and also hopefully get some idea of kind of who, and that's why we have Melissa on this podcast, who and how these are being financed, including in these other transitions like to hospice. But before we do all of that, which is a lot, I just realized, I think we have a song request. Melissa, do you have the song request for Alex?
I do. I'd like to request Live Like You Were Dying by Tim McGraw.
Why did you pick this song?
It sounds pessimistic, although the lyrics are not, and it's just about living life to your fullest, or at least trying to, wherever you are.
Wonderful.
You said I was in my early 40s with a lot of life before me, and a moment came that stopped me on a dime. I spent most of the next days looking at the x-rays, talking about the options and talking about sweet time. I asked him when it sank in if this might really be the real end. How's it hit you when you get that kind of news? Man, what you do? I went skydiving, I went Rocky Mountain climbing, I went 2.7 seconds on a bull named Fu Manchu, and I loved deeper, and I spoke sweeter, and I gave forgiveness I've been denying. He said, someday I hope you get the chance to live like you were dying.
Wonderful song. Thank you, Melissa.
Great choice, Melissa. I think that's the second time we've done it, but I do we've done over 400.
You picked a song that you've done.
I know, but we've done over 400, so I can think occasionally it's okay to return to songs. And we do get this request that has the word dying in the title. Any song with the word dying is likely to be requested multiple times in the JPL podcast. Thank you, Melissa.
So again, this podcast is a lot about transitions. I'm going to start off with you, John. You wrote a manuscript for JAGS titled Waiting for the Other Shoe to Drop, talking about your transition into a CCRC, or continuing care retirement community. Can you tell me why you decided to write this article?
Well, it was in my mind, and I thought it would be a good thing to share with people. Recall, it was written during COVID, so a very different time in the history of transitioning into retirement communities. Unusual because everything was isolated, and you couldn't suddenly become a real member of a large community. But once you get through that, there are very many advantages as you get older. It takes a whole lot of burden off your kids from worrying about you. My wife, for example, fell and fractured her pelvis about 3 or 4 years ago and simply can't get around without a rollator and can't use stairs effectively. So
And you were living in a big Victorian. Is that right?
Yes. Yeah. Yeah, so it goes around, comes around a little bit. But CCRCs are communities of people who realize they're aging and realize that they want to take potential burdens away from kids and have access to all things in healthcare without having to drive across the town or across the county.
And John, can you describe what a CCRC, my understanding, and I think this is great to have somebody who's actually living in it, is it's kind of the full spectrum from independent living to all the way to assisted living or nursing home level care that you kind of buy into.
Correct. Yes. So it's continuing care retirement community. You can live in the community in a cottage, which is what we do, or in a high-rise apartment, which is available on this campus. And it's just like you were living that in a regular community, except all your neighbors are older, and you end up suddenly realizing you go to more funerals than you do anything else because only old people are coming in. So you miss that connection with youth. But most people have families in the neighborhood. Families are coming to visit, so you see young people all the time. But the advantage is one campus, all care needs. So walk to the dining room. It's a little bit like being a freshman in college. You go and eat with folks and share issues, share histories. And I've enjoyed it because I met a lot of people who are not physicians. All of my friends before that time pretty much were physicians and local neighbors. But here I've met philosophers, engineers, aircraft designers, and it's just a fascinating daily encounter with people who are trying to age effectively.
What surprised you the most as a geriatrician about this transition from living in your Victorian house to this CCRC?
Yeah, it's a bigger shock than I thought because suddenly, almost like throwing an electric switch, you're in a totally different environment. Nobody's doing any cooking anymore. You go up for meals. You walk to the swimming pool. You walk to the gym. You walk in the neighborhood. You participate in many of the various activities. For example, I'm involved in the wood shop here, which has, maybe 15 or 17 members doing all kinds of repairs for people's chairs and doing other things like that. So it's a engaging, enriching environment from that point of view. Lots of new friends. Talked this morning for about an hour with a person who taught history in high school, and we discussed how he would be teaching about current activity, current history as it's unfolding. So it's just fascinating, engaging, intellectually challenged. More to do than you can possibly go to. There's a special lecture almost every day, really, and musical groups come in. So it's been very interesting and exciting.
Did you ever have that regret moment of like, oh my God, what did I get myself into? But before feeling like, oh, this is actually quite nice.
Well, again, the COVID issue spoils the answer to that question a little bit because you were isolated and you had to stay in your room and they brought food to you. So, but once that was over, the joy is really being in a neighborhood of people who are interested in education, interested in all kinds of activities, and meeting them on fundamentally a daily basis. It's like going to a small college on a little island in the Chesapeake Bay, and everybody kind of understands the issues, but everybody has a different history.
If I could reflect, there's a somewhat disconnect between the title and content of your JAGS piece, Waiting for the Other Shoe to Drop, which talks about the sort of homogeneity of people at the facility in terms of class and educational background, in terms of the sense that people were seeing each other grow ill, get sicker, die.
Yeah.
And that the tone of your piece was much more, I don't know if despairing is quite the level, but ruminative
Yes.
and a sort of more negative connotation than what you're describing now in the podcast. Any
Yes,
thoughts on that?
That's true. And again, I think it was related to the time and the problem of the pandemic that we were in, and the isolation and the absence of people coming to visit you. So you kind of felt isolated. That's all gone away. And now we're connected with the community, living north of Baltimore. We're involved with the local high school.
So you actually
doing
see some
teaching.
younger folks there.
Yeah.
Yeah. I'm an advisor to a couple of freshmen in high school at one of the local schools. They come here and chat. What is it like to
Yeah.
be old? That kind of thing. And then we go to the school and they make presentations and we talk. So that kind of thing is very engaging. There's a very active group in environmental issues.
And can I ask, John, how in general is CCRC paid for? So I'm guessing you give a lump sum and then you have a monthly fee. And then if you need more help, do you have to pay extra help? Do you know how that works? Like if you need more of the assisted living and nursing home?
The CCRCs were pretty much invented in the 70s, late 60s. And Broadmead, where I live, was the first in Maryland in the mid to late 80s. And at that time, it was all pay up front. Nowadays, you pay a major entrance fee, and then you have a monthly fee. Nowadays, more than half the people have long-term care insurance, which changes the dynamic. So if you have long-term care insurance, you don't need to be having the organization be the insurance company for you for all levels of care. So in my case, long-term care insurance for a number of years, you pay a much smaller entrance fee and a much smaller monthly fee, but you have to pay for long-term care if it goes there or things such as that. Fortunately, we've not had to use that. So Medicare covers certain things, for example, rehabilitation, which if you go, you have a fractured hip and you come back, then you go to the rehab unit. That's covered by Medicare. But in my case, if I had to go to a long-term care, couldn't care for myself anymore or something like that, then my insurance would start covering after, I think it's 30 days, something like that. So,
And if you didn't have insurance, you would just be paying for that out of pocket.
well, you'd pay it. The two forms of payment are the all-inclusive big entrance thing and a big monthly fee. Then it's covered by the institution.
Okay.
In this case, Broadmead. Or in mine, it's kind of an a la carte. Smaller entrance fee, smaller monthly fee. But if you need additional care, you're paying it out of your own insurance or out of your own pocket.
Okay.
So that's the change that's happened in recent years with the movement in long-term care insurance.
And do you know who owns your CCRC? Do you know anything about the ownership structure?
Yeah. It is a not-for-profit organization formed by a group of Quakers, really, from Pennsylvania. I'm not a Quaker, and maybe only 20 or 30% of the people here are Quakers. But not-for-profit organizations have formed these. There's a lot of for-profit organizations have gotten in this business too.
Yeah.
But we'll
talk about that. Yeah.
We'll talk about that.
Okay, a lot of them are not for profit, and they can't lose money. So it is a business, and the fees are high. But in my experience, the fees are less than what it costs to live independently in Baltimore. if you talk about maintenance of the house and insurance of the house and stuff like that, it turns out to be a little less, much to my surprise. And my dour paper, the other shoe to fall in, was really had to do with the isolation that was necessary at the time. And I think I changed that tone a little bit now.
Yeah.
That people come in now and they don't seem to have that "what have I done" kind of thing that happened during the isolation. And isolation was serious business. They brought your food in a paper bag every night.
Yeah. I'm glad to hear that things have improved so much, John. Thank you.
Yeah.
Well, I wonder if we can hear, Bill, your story. So you wrote another paper in JAGS, and this one was My Journey Through Assisted Living Facilities. Can you tell me why you decided to write this article? We'll have links to both of these articles in our show notes.
Well, a lot of the things that John has said would apply to me, but I will say that assisted living is a much more depressing and sort of a place where you don't want to be if there's any way you can get out of it. So fundamentally, when I went to assisted living, I'd had a bad fall. I'd had a brain bleed. I had broken hip and a broken shoulder, and I was delirious. And for better part of a year or so, I was delirious. I required either a rollator or other sort of assistance device to get around. I really required a wheelchair. I couldn't really get around independently. And so what John said about them bringing food into the room rather than going to a situation where people would eat together and share some social activities. In the assisted living facilities I was in, I only got food brought in, and there were no social activities for me and the other, what I would call, I called us all inmates.
Was this in COVID era, or is this kind of post-COVID?
This was definitely post-COVID.
Post-COVID.
In general, when you think about it, assisted care living facilities are at least half of all long-term care facilities or institutions in the country. That's what the data are, at least half. Okay. Now, in these facilities, they're very much like how we always have thought of nursing homes in the past in terms of the services they provide and the quality of the staff. Generally, what I found in assisted living is that there are no regulations that require, for instance, a chief nurse or a medical director. Now, some of the assisted living facilities do not necessarily care for people as debilitated as I was. So there's great variability in the quality and what you can say about assisted living facilities. But more and more assisted living facilities are going to be like you think of the nursing homes of old. The doctors are often not present.
Yeah.
There's often not a head nurse. And the nursing staff and other aides are, shall we say, spotty.
And can I ask, Bill, how was the decision made, do you know, for you to go from the hospital to either a nursing home or assisted living facility?
Very simply, with my fall, fracture, and other things, I was very debilitated. And recall I said that I was delirious. Now, I have normal pressure hydrocephalus. And so I was pretty much cognitively debilitated for over a year.
Yeah.
And, anyone would view me as sort of demented or pre-dementia. My ability to care for myself was very limited. So my ability to get out and do things.
Yeah.
My wife came to my room at the assisted living facility almost every day and was involved in my feeding. She actually hired some people to come in and help me with mobility.
But do you know Do you know how they chose to send you to assisted living facility versus a nursing home? Like when that
Yes, I do. Here's the interesting thing. And I dealt with some of this as a clinician, geriatric clinician. When I went through the fall and delirium, etc., if you look at the assisted living facilities that I was in, they look very much like nursing homes.
Yeah.
They look very much like federally evaluated and mandated sort of quality nursing homes. But there is a big difference in that assisted living facilities are only beholden to state level regulation, where standard nursing homes are beholden to federal regulation. I promise you, both as a clinician but major as a patient, the lack of federal oversight of assisted living facilities allows them to have less staff, less able staff, less medical input. And really, the patient outcomes, there's never been a study of this, the patient outcomes are not so great.
Do you regret going to an assisted living facility versus a nursing home?
I do, but regret is a good word. In a way, I don't regret. I was so delirious.
Yeah.
And I don't think, some of the doctors who decided to send me to these places really understood the difference between assisted living facilities and skilled nursing facilities. I tell you, there should be a major national study. This is a great study waiting to be done, and that is the level of care, the outcomes clinically of patients in assisted living are worse than the ones in either regular nursing homes or skilled nursing. And very little has been written about this.
Yeah.
It's astonishingly problem.
So,
go ahead,
John.
I was just gonna mention that assisted living is a form of long-term care, and I think it's a little different in each state how it's funded.
You're right.
And the requirements. But I think Bill's absolutely right. As a group of facilities, they generally are understaffed compared to a nursing home. At Broadmead, for example, there are all levels of care. I'm in independent living, which is living in an apartment like a community. But on our campus, we have an assisted living facility that certain requirements to get there and certain staffing, I think it's probably higher than in the community. And we have subacute care, and we have rehabilitation care, and we have memory care for people whose care problem is primarily memory. So that's a little variation of the theme, all different kinds of care that I think are more or less state specific. And assisted living is pretty dominantly a Medicaid program in Maryland.
Assisted living or nursing home?
Assisted living. Nursing home is much more Medicare because the rehabilitation stuff.
Oh, okay. So for short stay rehab, we're looking at Medicare paying for it. Medicare doesn't pay for long-term care, so they don't pay for any of this. Like in California, I know for if you have Medicaid, it's largely SNF, so skilled nursing facility, nursing home. And a lot of our assisted living facility is private pay. So it's kind of the wealthier people go to assisted living facilities, but it's this largely unregulated institution.
Poorly regulated, and unless it's incorporated into an all-inclusive institution like a continuing care retirement community. But assisted living, isolated, I've been in assisted livings that had 3 patients in somebody's home. I've been in assisted livings that had 40 patients. But generally, they're small, they're under-regulated, and mostly you pay out of pocket. So people very quickly go from self-pay to Medicaid.
That is correct.
Thank you, Bill.
Melissa, were you going to say something?
Yeah, I was just going to say, I think one of the things that's interesting about hearing your experiences with this is it demonstrates some of the areas that we talk about more theoretically of where we have to be careful around ownership and where we have to be careful about quality. because you both mentioned that in this transition period, first of all, it can be chaotic. Like you said, Bill, like you weren't even able to kind of be part of this decision about where you went.
Right.
And it's not only that, but it's you don't really know what to expect, right? And so you're paying for something. You kind of think you know what it's going to be like, but you don't really have a way to judge once you're there whether you're getting the services that you were supposed to be receiving or the care or whatever it is. So it's one of those areas similar to hospice, which I've studied, which has some of these unique characteristics about the transition that you think about that's very different from getting like an outpatient visit or a hospital service where you do it multiple times, you know what to expect, and there's some guardrails around the quality. So these personal experiences are really interesting.
Comment. What you just said is absolutely correct. I want to say again that our field of geriatric medicine and in general, healthcare and medicine in general, do not understand the limitations of assisted living and how assisted living facilities are often thought of in the same breath as nursing homes, and neither are great. In assisted living, the oversight, the supervision, sort of where the money comes from, and the type of care that's provided, there's not been a sufficient enough study on a national level. And also, the other thing a study can look at is that these facilities, I've looked at this, that they have a way of presenting themselves, ads and other things, as if they're a high quality, let's say, nursing home. And they really mislead the public and older people with a lot of disability. And this is, in my way of thinking, something that really needs to be further evaluated.
It needs to be figured out how to finance it properly. Right now, it's kind of a loose element that doesn't fit into anybody's category.
Yeah.
So it's not rehabilitation. It's not Medicare. You got to either self-pay or you become poor enough to cut Medicaid.
And that's if you're in a state where Medicaid pays for assisted living, which, again, I think you have to get specific waivers. Like, it's really, really complicated.
Yeah. But that's the reason, precisely the reason that continuing retirement communities are taking off, because now, as part of our payment, we have assisted living, we have memory care. Medicare jumps in if we need rehab.
Yeah.
So the continuing care retirement community business, which is growing rapidly, much of it is not for profit, but there are some profits that kind of are doing
this is
all of the care and orchestrating it to try to get control of it.
This is a perfect segue. Melissa was at UCSF, gave a grand rounds about the rise of private equity and really described the uptake of, or I don't know what, the rapid growth of private equity across many fields, the financing. And when you think, we had Melissa on previously in a podcast with Lauren Hunt and I think Claren Kuda about private equity gobbling up hospice. And what I loved about the grand rounds you gave here at UCSF was it described the bigger landscape of like what are the motivations of private equity? What are they doing here in terms of acquiring companies, breaking them up? How do they make a profit? How do they finance these acquisitions? What's going on with the mergers, the vertical and horizontal? We don't have time for a 40, 50-minute grand rounds, but we'd love for you to give our listeners some sense of what's behind this growth, because it's not just in hospices. It's happening in assisted livings. It's happening in nursing homes as well.
Yeah, thank you. Thank you. Yes. So I think private equity, of course, is not new, and its entrance into healthcare is also not new. However, it has transitioned over time in some interesting ways. I mean, the first investments of private equity in healthcare were in areas that were very removed from patient care, things like labs or imaging centers and things like that. Around the 2000s, it moved into hospital care and some specialty care, kind of getting closer to direct patient care investments. And what we've seen over the past, say, 8 to 10 years or so, but more like 8 years, is really investments in hands-on patient care companies like hospice, like home health, like behavioral health, where you're really looking at very vulnerable patient populations. And so I think that's a big transition, and it's something that people need to be aware of. We've studied a lot about the differences between for-profit and nonprofit healthcare providers. John mentioned he was at a nonprofit. More than half of assisted living facilities are for-profit. And we see very different patterns of care, different access to care, different quality of care. And private equity is kind of an extension of that. There's a lot of work now to try to understand its impact on patients and families. But it differs kind of from a regular for-profit investment in two ways. It's first a short-term investment. A company comes in and invests in something like an assisted living facility and wants to sell it fairly quickly, say within 5 years, and in that time generate a return. How do you do that? A lot of it can be around staffing, and we were talking about that before, how much staffing can vary. Not only the number of staff, but their training, their qualifications. You can change staff salary, so reducing salary, that can impact turnover. We know in the nursing home, staff turnover can be a big deal, right? And even if you're in assisted living, maybe you have like a home health aide or something like that. When that person turns over, it's very, very difficult to kind of train and get used to somebody else. So those are some big impacts on patients and families. And the second thing is the private equity's use of debt. And so when you invest in a company, when private equity invests in, say, a hospice or an assisted living facility, they do it by debt, by taking out a loan for maybe 80% of the cost of this investment. And so not only are you taking a company and trying to generate a return with the existing revenue and costs, but you've added this huge interest cost. So you really have to push the revenue even harder to get that return over a short time frame. And so that's kind of the gist of how they work. And I think that we are concerned about it in areas like hospice and areas like assisted living, because as you both described, there's very different regulations. It might be at the state level, it might be at the federal level. There's a lot of opaque information in terms of who is the owner, who's not the owner. And we don't really have great quality metrics in a lot of these settings. So how do we even know that people are getting what they need, what they expect, or what they paid for? So there's really a great interest in kind of understanding this emerging structure that's in these new areas of healthcare.
Yeah.
Great points. Great. We need work. We need to understand. Thank you.
Bill, do you know who owned your assisted living? You lived in two different assisted living facilities,
Yes,
correct?
I did.
Do you know the ownership structure, or was that completely opaque to you?
It was completely opaque to me. It was, private sort of equity investment, but I don't know who. I don't know exactly how it was structured. I know it was sort of a for-profit investment corporations.
Mm-hmm.
Yeah.
And by the way, my physicians who referred me to these places, who I love, they're my partners, really didn't have as good an understanding of the difference between assisted living, regular nursing homes, and other things. Our field needs to understand this better.
Yeah.
Mm-hmm. Melissa, I remember in your grand rounds, you gave an example of private equity, how they start before healthcare. I don't remember what that example was, but it was like their success story of we did this and we broke up this company and we made it profitable in this way. And then they came to healthcare and it seems to be somewhat different, although they're trying to replicate those experiences. Does that ring a bell to you? Is that?
Say a little more.
No? Okay, maybe not. But what I worry about is the challenge of what worked for Bain and Company or whatever, some private equity firm breaking up a merchandise chain and selling off smaller parts and making them profitable, consolidating, laying off staff. We should not apply that same model to healthcare, which has a different relationship with people based on like maintaining quality of life and good health, right? Rather than the profit motive. And what we're seeing is in this spaces like that private equity sees opportunity in these spaces with less federal oversight and regulation. And so they're seeing opportunity in, say, hospice industry, seeing opportunity in assisted living facilities. Yeah, exactly.
Yeah, thank you. And I think the example And what you worry about also is the financial health of these companies after they're purchased, and you kind of add on to them and add on to them, but you squeeze their balance sheet so much. There's a big risk of bankruptcy. About 20% of companies, once they go through private equity investment and sale, go bankrupt versus about 2% of other companies. And so if you think of an area where you live and you're moving into, say, an assisted living facility or something that's part of a roll-up, when that company goes bankrupt, what other options do you have? It's different from something like a toy company or some type of other commercial product where you can just get another product, or maybe it's something you don't absolutely need. I mean, we're talking about where people need to live as they age. And if an entire market, if your decisions were not only moving into these spaces, but moving maybe 3 hours away into the space, that's kind of a different decision. And so it's another type of risk in terms of the financial health of these types of investments.
And they're making a bet, right? Because as you say, they take on enormous debt, and they have to show returns that are greater than the interest rate that they're paying on the debt. So their incentive is to create tremendous profits rapidly in a very short time period. And that, I think, creates fundamental issues with healthcare as it's delivered, the staffing, for example, as Bill saw. John, I think you had a comment. Go ahead.
I agree with all that's been said here. It just seems to me that there's a lot of opportunity to get this right if you get the right people into it. And how do you get the right people into it? In my view, it's a great opportunity for major, large local healthcare insurers to get into that business, or even continuing care retirement communities to not just keep themselves on a campus, but begin to offer their services for people still living in the community.
Great point.
You got probably a lot of pushback on that, but to me, it's just an expansion of resources and just connecting a lot more with the community.
It feels like the two stories I'm hearing. Again, you don't want to make generalizations out of two stories, but like, John, you're working in a nonprofit Quaker institution,
right? Very
doing
different.
woodworking and
going to area high schools, mentoring high schoolers.
I think
very different.
And it's been around for what, 50 years? How long?
But
50
next
years.
month I could be in assisted living.
But it's still in this nonprofit system, right?
Right.
Versus Bill is in this for-profit, probably private equity owned or recently sold.
Mm-hmm.
And he's in an isolated company, yes.
The difference between the two stories is shocking. It's also honestly like the difference that we're seeing like hospice care is that we're seeing, these places that have been around for 50 years. I would say both the longstanding nonprofits and some of the longstanding for-profits, and then these fly-by-night, small for-profit entities that private equity is gobbling up, where we're seeing tremendous variation in care.
Good point.
And towards the end of our podcast, we like to get towards like, what can we do about this, right? We got to leave people with something positive. What can they do about it as a clinician? And it sounds like I've already heard they need to learn more about the differences between assisted living and nursing home facilities. We've already heard we need studies of the outcomes of people who go to assisted living facilities versus nursing homes. I think we heard from Melissa that we need more research about what's happening with private equity-owned assisted living facilities, hospices, nursing homes, and particularly longitudinal data. What happens over time to these sorts of facilities? What else can we learn about? Can the individual? Most of our listeners are clinicians, so like, what can the individual clinician do? We could start there, and then also what can we do more in terms of research and policy?
We'll start off with Melissa.
I think two things. I think as an individual, whether you're a clinician or not, I think understanding more about what's going on and being informed and understanding who kind of locally, politically, if or what they're doing about this, because most of the regulatory initiatives, at least the things states are trying, are state level, and some states are more engaged in this than others, and some political figures are more engaged than others. So I think if you become informed and understand where people stand on that issue, and then vote accordingly, I think is one thing that all people can do. And I think the other aspect, so you mentioned the types of studies that I think would be amazing to do. And I also like what both John and Bill have done, which is people who have experience, maybe a clinician's been at a healthcare provider that's been invested in by private equity and then kind of bought and sold, to kind of tell their experience, write about it so people can hear about it. Not as like a whistleblower, but just as kind of like, what were the positives? What were the negatives? Was there a change in culture? Like, what did you experience going through this? And I think those types of stories, qualitative research, as we would say, or just stories, can be really telling and really helpful.
Great. I also find it really interesting. Like, you can go on Medicare Compare and you can pull up like nursing homes, but it's not Medicare paid. So there's no assisted living facility star rating out there.
Right.
But that's why continuing care retirement communities could expand their services beyond a campus and into the community. I don't know anybody that's doing that, but let's serve a broader community than just a campus community. Because the resources, the insight, the knowledge of how you do this, healthcare has to be coordinated. The older you are, the more that's true. And then we've got to back up and get the hospitals engaged. They have no clue what a continuing care retirement community is or an assisted living community.
Yeah.
They don't know. Oh, they have a bed. Okay, great. Oh,
discharge length of stay.
Right.
Yeah. And I, in my experience as a clinician, have had some patients do that and have gone to visit these places and said, oh my, this isn't exactly what we thought we were getting. So I think there's enormous opportunity for growth and development, and we need to get it accelerated because the population's aging. And we need to make continuing care retirement communities more affordable for people without long-term care insurance. And again, I think if they expand in the community, you can begin to control costs.
Wonderful.
So come back in 10 years and we'll see where we are.
Bill, what's yours? Well, one thing we should focus on, kind of the concrete next steps.
Well, I think Melissa and John have both made very important comments. Fundamentally, the American public needs to understand these issues better. But frankly, our own geriatricians need to really look at these things more objectively and really push more for better reorganization of long-term care. So that's all I have to say.
Mm-hmm. And one other piece I took from your essay, Bill, in JAGS, was that there was a disconnect, that you and your wife did not feel like goals of care were adequately assessed, and that goals were presumed to be purely palliative in nature, whereas you and your wife, your goals for you were organized primarily around improving function.
I want to be careful about who I make mad by my comments. But let me just say that even my physicians thought I needed palliative care and was going to die. That was true of many of the people in the skilled nursing facility. The overall gestalt was that these people are going to die of need. And they did do some pretty good stuff with palliative medicine. So bottom line is, we, the leadership of this geriatrics, we need to look at this and redefine the perspective so that our members can be appropriate, understanding advocates for better care in these facilities.
Oh, I love that. We'll end with that. Alex, a little bit more.
I went skydiving, I went Rocky Mountain climbing, I went 2.7 seconds on a bull named Fu Manchu, and I loved deeper, and I spoke sweeter, and I gave forgiveness I've been denying. He said, someday I hope you get the chance to live like you were dying.
Bill, John, thanks for joining us on this podcast. And also just big thank you for sharing your own experiences with these transitions. And Melissa, always great to have you on.
Thank you very much.
And to all
Thank
of our,
you. Keep
to
up
all
the
of
good
our
work.
listeners, thank you for your continued support.
You guys are great. Thank you.
We'd also like to do a special shout out to all of those supporters who've donated more than $250, including
Brian Castle, Victoria Brond, Susan and John McFadden, Christopher Heck, Emise Samoji, Matt Schuster, Carrie Hagan, Lloyd Woolstat, Kari Levy, Marnie Fetzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Young, Cindy Harris in honor of Emily Guillot, April Sear, Anna Naik, Xinyi Wang, Sudha Chandrasekhar, Michael Reisner, Asher Edwards, Susan Nelson, Rebecca Goldstein, Rochelle Bernacki, Carol Dietrich, Mark Andrews Wren, Elizabeth Cobbs, Amy Rack, Meg Walhagen, Xinyi Wang, Sharon Bragman, James Tulski, and Yana Scharf, Kelly Strait, Michael Bordowski, Jessica McFarlane, Gretchen Schwarzy and Joshua Mesrich, Rob Razak, Diane Meyer and Sean Morrison, Elizabeth Chung, John A. Hartford Foundation, and Harry Hahn.
Thank you very much for your continued support over the last year. Your support keeps these lights on.